Session 12. Session 12 is the end of our sessions. For this course, there's 2, 3, 5, normal labor and puerperium. In session 12, we are discussing minor disorders of the puerperium. If we say minor disorders, it means that they are not life-threatening. The puerperium is characterized by the return of organs to their pre-gravid states as much as possible, and it's a period where lactation is also established and there is recuperation from the physical, hormonal and emotional experience of pregnancy and labor. The minor disorders are not life-threatening, like I said, and they could be managed. These include after pains, hemorrhoids, retention of urine, and then there are several others. Also, other consideration is the management of the minor disorders of the puerperium. Session goals and objectives. By the end of this session, I presume that you'll be able to differentiate minor disorders from life-threatening conditions and the puerperium, effectively manage the minor disorders of the puerperium, and refer where appropriate. This is our session outline. We'll be looking at some of these minor disorders, but we may not exhaust all. And this is our major reading list. So for topic 1, we want to define minor disorders. And we have said that minor disorders of the puerperium are those that are not life-threatening and can be managed effectively without any referral. These disorders may include after pains, hemorrhoids, subinvolution, engorgement, retention of urine, and all the others as we mentioned earlier on, also including puerperal blues. Let's look at after pains. After pain is defined as the pain that happen after delivery in the uterus and is due to spasmodic uterine contractions. The incidence, it is common with multiparous women, and it is caused by the uterus contracting strongly in its attempt to expel clots or pieces of membranes left in the uterus, especially when the fetus is suckling and oxytocin comes in to bring contraction not only to the breast but also to the uterus. Signs and symptoms: you have some bulky uterus with blood clots, telling you that there is something retained and the woman is pressing hard. The uterus is pressing hard to expel the content. So you express the uterus of any clot and then you give any analgesia if necessary. Now let's look at hemorrhoids. The pressure of the baby's head on the anus during perineal phase of labor could cause some hemorrhoids to be formed, and which may sometimes prolapse and cause pain and intense discomfort. The hemorrhoids may bleed, and to relieve the symptoms, you give sodium chloride soaks. You apply it to the hemorrhoids for 48 hours, or application of a soothing ointment can be comforting. Subinvolution. In this condition, there is delay in the return of the uterus to its pre-gravid state. So we have a bulky uterus. Lochia are profuse and reddish brown. Remember that we said that the lochia should be coming from red to pink and to white. So if at any point we started from red, we got to pink and we go back to red, it's telling us that we have subinvolution. The final height remains stationary for a few days because we have said that there is some discharge and the uterus is bulky. The uterus is also not just bulky, but it's also soft, and the discharge may also be profuse. The causes: anything interfering with proper contraction of the uterus, example, full bladder, full rectum, or retained products. Local uterine infections. The presence of uterine fibroids. When there are uterine fibroids in the uterus, it prevents it from contracting fully. Yes, in the previous session where we were discussing how the uterus is able to cause hemostasis, we spoke about the living ligatures, and we also mentioned apposition of the uterine walls, where the uterus tries to press on itself and cause hemostasis. But then if you have multiple uterine fibroids in your uterus, we cannot have apposition of the uterine walls because the fibroids will come between the uterine wall and the uterus cannot contract adequately. In gland multiplicity, imparity, where the uterus has lost its tone, we could also have subinvolution. The management: the lochia should also be closely monitored, the cause is investigated, and treatment is given accordingly. We want to look at breast engorgement. Breast engorgements could be prevented when we have early recognition and active treatment when we detect it early and manage it actively. The main prevention for breast engorgement is putting the baby to breast very early, within the first 30 minutes, or the first 1 minute, and asking the woman to breastfeed whether the breast milk is coming or not. The breast should also be supported with a firm maternity brassiere or breast binder. If the woman just leaves the breast to suck, then it pulls and then there is pain. Analgesics may be given. The mother should be encouraged to feed baby on demand. The breasts are hot bath before feeds and gently stroked with soapy hands or warm oil towels on the nipples. There is manual expression be attempted. If it's very full, sometimes you can't even create a nipple for the baby, and then maybe they need to do some manual expression so the nipple can become erect, and then you breastfeed. After delivering the baby should suckle the breast at frequent intervals, provided both mother and baby are in good condition of health. Engorgement of the breast, like I explained earlier on, could be due to incomplete emptying of the breast, because baby is feeding but not feeding adequately, and then engorgement occurs. Normally around the 3rd to the 4th day after delivery, where the milk is being produced, the baby is not sucking very well, then it's retained and it causes engorgement. It could be due to poor attachment. If you feed the baby on the nipple and not the areola, then the breast will be engorged. The nipple doesn't contain any milk. The milk is stored under the next to the nipple. And if the space after the nipple, that big space. So if you just let the baby hatch onto the nipple, then you are not going to get the baby breastfeeding. Signs and symptoms: there is a sharp rise in temperature. You may have rapid pulse. You could have throbbing pain in the breast, and the breast becomes very soft and tender. It's very tender to touch, and there is general malaise. The woman complains of headache, and sometimes she experiences rigor. Veins may be visible on the breast, and the nipples will become very flat. I want to look at backache. It's a common complaint, and it is mostly of the women who are poorly nourished, overworked, multiparous, who have lax muscles. It is prevented through education on good nutrition and maintenance of good posture, especially when they are breastfeeding. They have to support the back straight, and if they don't do that and they coil over unnecessarily, then they'll end up having back pain. Retention of urine. It is less common since early ambulation was inaugurated, but occasionally occurs following a difficult delivery. An over-distended bladder may have been bruised by the fetal head, like I said earlier on, and there is bruising of the urethra and bladder neck, which took place during the second stage when the bladder became an abdominal organ. You can have edema of the vulva. And then when there was an episiotomy or suturing of the perineum, anytime the woman urinates, she experiences pain and therefore keeps the urine. If there is lack of privacy and difficulty in using a bedpan, this patient may also experience some retention of urine. Some, they are just afraid that they will have pain, so they will not urinate. You do the following observations. You monitor the amount of urine passed and record. Keep a good or strict intake and output. And then, when less than expected, the cause of the retention should be investigated and the appropriate measures taken to correct it. The height of the fundus should be measured to note any displacement caused by a full bladder, and then measures that will encourage emptying of the bladder should be first tried. If unsuccessful, then a catheter must be passed. So you set the woman a bedpan and ask her to void. Some will prefer standing and voiding. Some, when you turn on the tap, they will begin to void. All these things are strategies that will help initiate the urine. If for any reason it is still not coming, then we need to pass a catheter and bring out the urine. Now, if there is no urine at all, then it means that this woman may be having some kidney shutdown. Now I want to talk about cramps. They are painful contractions of the muscles, especially the calf muscles after delivery. Remember that anytime you have pain in the calf muscles in the postpartum woman, it could be a sign that she is developing thromboembolic disorder, and it should be taken seriously. So that if we have managed this woman very well during pregnancy and delivery, and we have encouraged early ambulation after delivery and postnatal exercises, then the woman will not experience the cramps in the calf muscles. Finally, we have puerperal blues. Remember that anytime we talk about puerperal blues, we will differentiate between the puerperal blues and other abnormal conditions that can happen in abnormal puerperium, such as puerperal psychosis and puerperal depression. Those are severe psychiatric conditions during the puerperium. Puerperal blues are part of the physiology of the puerperium, and they are just a minor disorder that can be managed. It's also known as baby blues. It's normal in some postpartum women, and the new mother experiences tearfulness. For no reason, she begins to cry in bed. If you ask her, she can't tell exactly why she's crying. She has irritability. She easily gets angry. You come to her, you talk to her, and she gives it back to the midwife. Sometimes she has sleeplessness the whole night. We see her pacing up and down. Not just because baby is crying, but just because she can't just sleep. The causes, you have hormonal fluctuations. You could have physical exhaustion, and then maternal role adjustment. If she has difficulty adjusting to her maternal role, she may experience puerperal blues. Everybody is complaining, I'm not breastfeeding my baby, my breast is engorged, I'm in pain. Nobody sympathizes with me. All they care about is that feed your baby, feed your baby. And this woman can easily develop puerperal blues. She can't adapt to her new rules. You reassure the mother that it is normal, it will go in the course of time. You guidance and individualized support from healthcare personnel. You inform the partner and other people around the woman to support her. You keep communication lines open so she can call, discuss her problems. You allow the mother to make many decisions as possible. So look for her choices, and then once she feels she's in control, it helps her deal with the puerperal blues. And then you allow her to verbalize her feelings and concerns. You don't shut her down. If she complains about something very minor, you don't shut her down. Sometimes a teenager and comments like, you want to do what your mothers will do now, you can't bear the consequence, will easily put this child into puerperal blues. So you support accordingly. In summary, minor disorders of the puerperium are not life-threatening and can be managed. They are disorders that are likely to occur during the puerperium, especially with new mothers, and they are educated and prepared. And if this is done adequately during pregnancy, they will be able to manage it, and most of the disorders will be prevented. These are the references, and we've come to the end of our course, Nurs 235, normal labor and puerperium. I would advise that there are other references in the footnotes. Read them, go online, do further readings, and try to answer some of the questions that will be put up on the platform. Thank you for the audience.